I would also like to share with you several breast cancer patients' cases that were very complex and at the same time successfully resolved. The first case I want to draw your attention to is one that is commonly depicted as a very poor prognosis, difficult to treat case. I had a woman in her mid-50s who presented with a left breast mass that was quite large and palpable, of at least 5 centimeters in diameter, with 2 what they would call satellite lesions outside the mass of either 1 and 2 centimeters, as well as some palpable axillary lymph nodes. Because the mass was close to the edge of the areola and the nipple, it was determined that she should have some kind of preoperative treatment. The patient had already made her decision that she was going to undergo a total mastectomy. However, her number one goal at her young age was to maintain and become cancer-free. And she had triple negative breast cancer pathology. So ER negative, PR negative, and HER2 negative is considered a very poor prognosis because the traditional way of treating is the mechanism of thinking is that if you have a receptor positivity in a tumor and you can block that hormone receptor, then you have a better chance of treating. When you have triple negative, there's nothing to block. You have to just treat and hope that you can get a good result. So I did perform the RGCC Economics Plus test on this patient to determine what chemotherapeutic agents would work best. I did combine low-dose chemotherapy in a number of sessions along with immune boosting treatments of salicinium and mistletoe. And the patient underwent approximately 2 months of treatment, which was our kind of general plan, before she should have her surgery. Now, I'm pointing this out because sometimes when you use treatments that block the energy making of cancer cells, whether it's salicinium or 3-bromopyruvate or some of these other substances that are out there, the tumor mass may not shrink significantly. When I took care of this patient, I gave her the treatment I described basically, and then before she went to surgery, I examined her, and the mass itself was not that much smaller. The satellites were gone, but the primary mass was still big. Lymph nodes in the axilla were resolved. So we thought, okay, fine, let's see what happens at operation and pathology. So the patient did have a mastectomy. She did have a sentinel node dissection in her axilla. And interestingly, out of the 5 centimeter spongy mass that I could feel prior to her surgery, only 0.7 centimeters was left that was cancer. The rest was all resolved. So that spongy mass represented dead tissue. Her axillary nodes were not positive either. So this was a remarkable result, and this patient to this day, years later, is disease-free. And I think it's a good testament to show that if you get directed and proper knowledge of what susceptibilities the tumor cells are and do other things to boost the immune system, you can get a marvelous result and put aside that fear of receptor positivity or negativity. The next case I want to talk about is a patient who had HER2 positive breast cancer. So she was ER negative, PR negative, and had her entire breast engorged with tumor, to the point where the left breast with the tumor was about 2.5 times the size of her right breast. Additionally, she developed a tumor of the nipple, which elongated into about a 5 centimeter tumor sitting on top of the breast. None of this had broken through the skin, but it was a significant volume of tumor mass. She was tried a number of different popular treatments that are used in treating cancer. One of them is the endolaser. Another is ozone topically, and methylene blue. She was referred to me because despite all the efforts to treat her with these modalities, nothing worked. Tumor was getting bigger, and there was a concern that the nipple tumor was going to start ulcerating, so they referred her to me. And because she was HER2/neu positive, I recommended that she do undergo the standard treatment with Herceptin, the monoclonal antibody that is directed towards that particular receptor, specifically made for that. The patient refused to take Perjeta, which is another monoclonal that is commonly accompanies the administration of Herceptin but carries a lot of neurologic side effects, so she opted not to do that. We did the RGCC Onconomics Plus test to find out what other chemo agents were going to be effective for her, and utilized a combination of other agents and Herceptin every few weeks. We tried the first session of using Herceptin once every 3 weeks, and it really didn't work well. So we decided to experiment and use it in a lower dose once every week for about a month, and along with the adaptive immune potentiated chemotherapy and the immune system boosting agents. And this seemed to be exactly what this patient needed, and it resulted in complete resolution of the entire breast tumor. Her breast is now the normal size compared to the contralateral breast, and the nipple tumor is completely resolved, and the nipple has shrunk back to normal. We had the opportunity to get pre-treatment and post-treatment thermograms, and of course the pre-treatment thermogram of her left breast with the tumor was red hot and fully abnormal. But post-treatment, it was, both breasts were green and normal, and very exciting result. She did develop a small residual area of hotness in the thermogram in the lateral portion of the left breast, and underwent some other subsequent treatment, and this is now resolved. And the axillary lymph nodes that she had that appeared positive on scan are all negative now and shrunken. So this is a marvelous result, and it's an example of how you can integrate traditional therapies along with these integrative therapies and get an amazing result even without a surgery. This is a patient who did not want to have breast surgery, and she did not want traditional chemotherapy. So we came up with a plan that she was able to accept, and was very successful for creating the result that she wanted. She is also now on oral maintenance with another anti-tumor treatment that we offer in the clinic, and she's going to do very, very well and very happy. So I just wanted you to have a little bit of a picture of how we combine everything we can to help solve each individual patient's problems. This is the way I like to work, and I enjoy help my patients get a great result when other people said, oh no, it'll never work. So I invite you, if you have a problem and you want to have some advice about it, make a consultation with me, and we can talk about what we might be able to do to help you achieve your goals. Thank you so much, and hope to talk to some of you soon.